Hello, everyone. Thank you for joining us. We'll start the presentation in about a minute or two, so get settled in. All right, thanks. Hello, everyone. Thank you for joining us. We'll start the presentation in about 30 seconds. Hello, everyone, and welcome to today's Safety and Health webcast, COVID Plans 2.0, What to Use and What to Lose, presented by Avetta. This is Alan Ferguson, Associate Editor at Safety and Health Magazine. I'm moderating today's presentation. On behalf of the National Safety Council, we hope that you, your loved ones, and all the people in your lives are remaining safe and healthy wherever they are. We'll start the presentation in a couple minutes, but first, there are some housekeeping items. As a disclaimer, the views of today's speaker and organization are their own and do not necessarily reflect those of the National Safety Council or Safety and Health Magazine. Any mention of a commercial enterprise, product, or publication does not mean the council or the magazine endorses those items. After today's presentation, we'll conduct a question and answer session with our speaker. To ask a question, click the Q&A button at the bottom of your screen, type your question, and click the send button. Please feel free to ask your question at any time during the presentation. You don't have to wait for the Q&A to begin. We'll try to answer as many questions as possible. We might not get to every question. The good news is that any unanswered questions will be forwarded to today's sponsor. Also, after this presentation, you'll be asked to complete a brief evaluation survey, and I'll tell you more about that a little later. This webcast will be archived so you can access it after today's live event. To view this webcast and all of our past webcasts, please go to safetyandhealthmagazine.com/events. With that, let's introduce our speaker. Dr. Shannon Magari, Principal Owner and Vice President of Health Sciences at Colden Corporation, a workplace safety and health consulting firm. Dr. Magari helps clients in determining the origin and nature of occupational health concerns. She has evaluated a number of industrial and non-industrial settings covering a range of occupational and environmental clusters involving cancer as well as reproductive, cardiovascular, and respiratory illnesses. Over the past year, Dr. Magari and her team have developed COVID-19 safety plans and conducted workplace audits to predict those working in industries such as energy production and distribution, hospitality, higher education, retail, healthcare, food, pharmaceutical, and television production. Dr. Magari holds a doctorate in occupational epidemiology from Harvard University, a master's in public health from Boston University, and engineering degrees from Dartmouth College and Syracuse University, and is the president of the Northeast Biological Safety Association. Again, we thank you all for tuning into this presentation. Dr. Magari, whenever you're ready, go ahead and take it away.
Alan, thanks so much. Hopefully everyone can see the screen. So good morning, good afternoon, good evening. I think we got a great group from around the globe. I want to just shout out to all of my fellow environmental health and safety practitioners. You know, kudos to you all. I think our healthcare workers, and I live with a doctor, my husband's a physician, and they all get the glory, and the doctors and the nurses, and they have been working hard and they're our heroes. But I think right underneath that would fall our environmental health and safety professionals. And so where are we at? You know, around the globe, we're in different spots. And I think I'll try to have a global focus here. A lot of this is US based since this is where I am. But we'll try and get in notes that everyone can use as we're really thinking about trying to update our plans. I think all of my clients internally for my own organization, I'm literally every month, it's sort of like, what's new? You know, we're up and we're down, we're changing, new variants. The more we know about modes of transmission and mitigation, the more we're going to need to keep updating our programs. So I'm just going to give you a quick background, where we're at, where we're on, what concepts we need for transmission, and then really focus in on what we should have in our plans. And a fair portion of that is based on the vaccines. And so what we know about them. So I'll spend, a little bit more time on that than some of the other mitigation strategies like ventilation and such. And then I have, a slide at the end of my predictions of where the heck we're going with all of this. I'm going to talk for about 45 minutes and then try and take as many questions as we can at the end. I want to start with this slide just as a way to say, there's too many people talking. I think that the 1 or 2 year look back on this is that there was just so much information out there, a fair portion of it, unfortunately, biased and just flat out false. So really make sure you're getting your information from vetted sources. The CDC and the World Health Organization would be my top choices there. I've got a picture here of US case counts. Things are peaking at different times throughout the world. We're lagging here in the States with the Delta variant, but we're amidst another wave. And I don't think, anyone who's had this before or after is going to argue that, we're still in the middle of this pandemic. Want to make sure we're level set on the routes of transmission. The routes of transmission have always been for the parent alpha, beta, gamma, and now delta. The main route of exposure is inhalation. The absorption fomite route from dirty hands to eyes, nose, and mouth, definitely a lower portion. We're not really seeing anything for ingestion. I'll avoid giving you the computational fluid dynamics of the particle physics lecture here, but make no mistake, the SARS-CoV-2 virus is one of the main transmission routes is a large aerosol component. Some large droplets, less than 100 microns, are going to be certainly modes of transmission, but they're going to fall out very quickly, within a few feet, a meter or two, and largely controlled with source mitigation or masking. The component that we really want to think about are those medium and the small aerosol droplets, in particular, less than 5 microns. They're going to travel a distance. Okay. It took us environmental health and safety professionals banging our fists to say, look, these numbers last year, we wouldn't have had such crazy spread without a significant aerosol component. And I think the word aerosol is very scary, right? The US CDC didn't recognize aerosol transmission until last October. I mean, it was crazy. So now that we know what we're facing, we recognize it, we can begin to mitigate. I think I put this up here because I really want everyone to understand the virus is just doing what the virus is going to do, which is to vary. So this is the family tree, the phylogenetic spreading of the virus all the way from, in our lower left-hand corner, the parent virus last December. All of these variants have been tracked. Some of them just aren't that biologically interesting, right? But this virus is going to continue to vary till we can limit transmission largely with vaccination. So I want to make sure we're all on the same page. Just going to go back to high school biology for a second. My vaccinologist friends and virologist friends cringe because people use the words mutant, variant, and strain sort of interchangeably. And I want to make sure that we're all on the same page with the lingo here, because it does motivate the conversations we have about the Delta variant and future variants going forward. When a parental strain of a virus mutates, right, when it copies its DNA over and over again, it's going to make mistakes, right? So think about laying down a brick wall, 1,000 bricks every 10 minutes. You're going to make some mistakes, right? And those are mutations. When those mutations take hold and lend the virus some interesting property, some interesting biological behavior or whatnot, we label it a new strain, okay? So make no mistake, if we stop the spread, we're going to stop mutations, we're going to stop various variants from taking hold, okay? And again, we do that with the vaccination primarily. So the Delta variant is the dominant strain in the US, it's the dominant strain in most of the world now. The symptoms are definitely appearing more quickly. There's a shorter incubation time period. Interestingly, we've got to be careful. We got good data from Public Health England. The main symptoms of Delta tend to be a little different than those of the parent strain. We're not sure if that's because of the Delta variant is just different, or if it's affecting a little bit of a different community, younger community. But the main symptoms of Delta tend to be headache, sore throat, and runny nose, as opposed to parent strains, which was fever, continuous cough, and loss of taste and smell. Okay, and so this comes into screening, making sure we're doing good daily screening. So what do we know about Delta, and how is this going to affect our planning? We know it's highly contagious, right? If fully vaccinated individuals can spread the virus to others. I got a whole slide on that, because we got to talk people back down a little bit. I think that people are qualifying the vaccine as having failed, all right? And we got to reset that expectation. There's some early evidence that it may be causing more severe illness. It is definitely evading natural immunity. So having had COVID does not completely protect you from getting it again. We know that our tests are still working, right? So it hasn't evaded testing. Some interesting things in some various targets are going dark, but we're still good. Can it evade treatment? The treatments that we have now are generally pretty broad spectrum, antivirals, steroids, and things like this. Some of the monoclonal antibodies treatments are going to need to be tweaked based on various variants. So why is Delta more infectious? It is figured out how to make a crazy number of copies of itself very, very quickly before your immune system has time to mobilize fully, okay? So the incubation period of Delta is just shorter, about 3.5 days compared to the parent. And the viral loads are about 1,000 times higher than the parent strain, okay? So this should look familiar to all you EHS professionals. We got to keep driving people back to this. We've got to get our plans aligned with this. And in fact, these are your 5 headings, right? Or 4 headings, because we don't have a really good substitution. Although I think anybody would take the common cold or flu over this virus now, but really want to, whatever situation you're in, whatever organization you're in, whatever is available to you now, and I fully recognize that vaccinations are not available to the world, and we need to do better for that, okay? That does not leave us defenseless. We've got to see and really have a good brainstorming session about what can go into our plan in each of these strata. What has gone in and out of these strata or options has changed throughout the pandemic as, you know, vaccinations become available, as PPE has come and gone, as we know more about administrative controls, about cleaning and the role of distancing. The plans have evolved, but make no mistake, this is the way to mitigate the risk. When we think about elimination strategies, we have vaccinations, daily screening, and testing. So when we think about vaccination, and this helps us reframe why we vaccinate people, most of the time we just vaccinate people, importantly, to prevent severe disease, hospitalization, and death. And I think that was a surprise to a lot of people. They're sort of thinking, well, I got vaccinated. Why am I getting sick now? Why are we having breakthrough infections? In fact, achieving a sterilizing immunity or completely preventing people from having infection for SARS-CoV-2 is largely going to be difficult / impossible. The vaccinations are performing well for what we need to. They're performing amazingly well against protecting people from hospitalization and death, which is what we need to get out of this pandemic. So resetting people's expectations as you're writing up plans and you're asking people to get vaccinated as health and safety professionals, it's really important to help them understand the purpose of the vaccination was to prevent hospitalization and death, okay? So the COVID vaccines were meant to produce antibodies circulating in the blood to prevent hospitalization and death. To prevent both infection and serious illness, you have to tweak the immune system, okay, and elicit a response in both the blood and the upper respiratory tract in your nose and throat, okay? This is a very tall order. Most vaccines can't do this, okay? So resetting folks to understand what the purpose of vaccination was. I grabbed Pfizer, Moderna, and J&J, and I think, you know, a fair portion of the world is getting vaccinated with AstraZeneca. The numbers for J&J are mirroring that. AZ tends to be a little bit higher in some of these, and these numbers literally are changing daily as we get more information. But I think right now for preventing hospitalization and death, the far two right columns, you can see all the high numbers, right? So, and AZ falls into this category as well. Crazy high effectiveness at preventing hospitalization and death. When you look at preventing symptomatic illness, we're having a hard time, right? You're seeing breakthrough infections, again, not a vaccine failure, okay? In different populations, in vulnerable nursing home patients, in general population, we're seeing reduced efficacy for the Delta variant against preventing symptomatic illness, okay? Somewhere between 50 and 80%, depending on whether you have a vulnerable population. In the 50s in the vulnerable populations, in the 80s for the general population, a little bit lower for J&J, but again, crazy effective at preventing hospitalization and death. In the United States, I can tell you that nearly all the hospitalizations and deaths now are among the unvaccinated. Okay, so we know what's going on. That's why we're talking about booster shots for some folks. The concept of base rate bias is really important. Again, I think to frame the breakthrough infections that are happening, I think it's scaring a lot of people, right? And so this is just a math problem, okay? As you get more vaccinated people, more infections are going to happen in vaccinated people. Doesn't mean the rate is any higher. Okay, so if you take 100 folks, you got 80 fully vaccinated, 20 unvaccinated, you've got 4 infections, 2 in the fully vaccinated, 2 in the unvaccinated. You can see the rates, 2.5% and 10%. So the rates are still good, right? This is a gross example. But the news headline is going to say, of those 4 infections, 4 were 50% were fully vaccinated, right? So do you see the problem with the math? So just be circumspect when you see these kinds of headlines, okay? The US CDC in May made a decision. I get it. They're only going to track hospitalizations and deaths, and there just isn't enough time, resources, et cetera, to track all breakthroughs. We've got good numbers coming in from various other HMOs and the Kaiser Family Foundation and whatnot to check asymptomatic and symptomatic breakthroughs. The UK has a great study going on to look at asymptomatic breakthrough. For what we know now, the breakthrough infections that have resulted in hospitalization and death are very, very rare, okay? You take the numbers that they're reporting, and it's even lower than this, okay? Because some people land up at the hospital for other reasons other than COVID, and they get diagnosed with COVID. So somebody breaks their leg, they've got to go to the OR, they're going to get a COVID test. So they didn't get to the OR, or they didn't get to the hospital for COVID, they got there with it, right? So these numbers are even lower. But for hospitalization, we're looking for among the vaccinated, there's a 0.0047% chance of being hospitalized. There's a 0.0011% chance of dying after you've had the vaccination. Okay, so again, crazy effective. Where are we at with boosters? And I understand this is can be a contentious subject around the world when some folks haven't gotten one vaccine. What we're learning, we certainly can apply. Antibody titers are still holding for most of the general population. We're still following trial participants around the world that got enrolled last summer, and we're going to watch them very closely. But we're seeing that in the face of the Delta variant, which is cooking up crazy copies of itself and is highly contagious. Okay, vaccines are holding up very good for hospitalization and death. We're seeing some reduced efficacy against infection, symptomatic infection. Okay, so in the US and many parts of the world, we're delivering third doses to immunocompromised populations, solid organ transplant patients, severely immunocompromised patients for a number of conditions, okay, to boost their immunity. The overall need and frequency for boosters is going to depend on the emergence of the variants. And it's going to depend on how quickly we can vaccinate to tamp down. Remember, the virus will vary within me. if I'm vaccinated, everybody around me is vaccinated, even if I'm infected, the chance of passing on that variation, that mutation to somebody else is much lower. Okay. So starting this fall, our internal US ACIP is going to meet and talk about giving the general population, not just the immunocompromised population, a third shot. We know we've got some good data from Israel that it works, right? So they were seeing an increase in these breakthrough infections. They started giving folks over 60 shots, and pretty quickly after that, we again watched the case rates fall. Okay, so stay tuned on that. Transmission after vaccination for Delta is quite possible. It was not that. We didn't say that for the parent or alpha, beta, gamma, but for Delta, again, cooking up crazy numbers of copies of itself. So we have good data from Singapore that tells us for the first few days of infection, about first 5 days of infection, there's similar viral particle loads. Okay, and yesterday we had a preprint article from the Netherlands. So this is good. So the first few days, we're seeing similar viral loads, quick drops in the vaccinated folks, extended periods in the unvaccinated folks. So much longer symptomatic period and infectious period for the unvaccinated. But yesterday we had an article from the Netherlands, a couple hundred folks in a study of healthcare workers. They actually looked at the viability of those particles. So remember, the NAT tests, your PCR tests, are very sensitive. In fact, we've got evidence of people being infected with SARS-CoV-2 and testing positive for a very long time, well after they're better and not infectious, right? So these PCR tests are very sensitive. But we know that those folks are infected, they're not infectious. Okay, so this study from the Netherlands helped us understand how viable or how infectious someone was. So among those vaccinated folks that have pretty high levels, viral loads, we're seeing a little bit reduced viability of those particles. So the immune system's kicking in. Okay, so that's good news, right? We know the infectious period for the vaccinated infected is significantly shorter. They have milder symptoms, generally asymptomatic or mildly symptomatic. And we know that mildly symptomatic or asymptomatic people can transmit, but it's less likely, right? If you're not coughing and sneezing and such. Okay, so again, this should motivate continued mask wearing even in a highly vaccinated population when there's high circulating transmission rates. I want to talk about natural versus vaccine-induced immunity. Okay, natural infection does provide some protection. It's not terribly durable. Okay, so we're seeing 6 months. We see much lower than infection rates than naive folks. After that, and this is with other beta coronaviruses, so you see high titers, concentrations of antibodies, and they start teetering around 6 to 8 months, and then around a year, the circulating antibody is gone. We may have some immune memory, but the circulating antibodies are gone. We have studies that tell us the unvaccinated folks who've had COVID are more than twice as likely to be reinfected. Okay, so we certainly have evidence of reinfection compared with people who are fully vaccinated. Having had COVID doesn't necessarily mean you've got response, right? So we've got some infected individuals who did not develop any neutralizing antibodies. Okay, we know that the antibodies induced by vaccination produce high titers. They have specific binding domains that are going to bind more strongly to the virus if you see it. So make no mistake, you can't count on natural infection to protect you. Again, another reason we want to push vaccinations in our health and safety programs. So for reinfection, the World Health Organization keeps logs of these things. We have seen evidence of reinfection. Certainly some reinfection of Delta after people have had Beta. We're watching some spots in Brazil, and our Brazilian colleagues have been watching Manaus very closely to understand the reinfection cycle that's going on there with P1 and P2. Okay, so even if you've had COVID-19, the CDC and the World Health Organization still do recommend vaccination for sure. I want to just take us one tiny diversion here into the flu vaccination. Okay, so I understand that not all the world has access to the COVID vaccinations. A fair portion of our population, 20+% of our population is under the age of 12 here in the United States. And they can't get the COVID vaccination, but they can get a flu vaccination. Okay. There is something about getting a flu vaccination that helps us fight SARS-CoV-2. Okay. So there's actually a couple things. There's an adjuvant in it, MF59, that helps potentiate the immune response. So there's no cross-reactivity with the antibodies, but the flu vaccination tweaks certain parts of the immune system to react. So it's going to increase our natural killer T cells. It increases our ACE2 antibodies. There's other things that happen that help us respond to a SARS-CoV-2 infection. And so we have data that tells us, sort of 30, 60, 90 days out from a flu vaccination, those folks who are, unfortunately get COVID-19 have reduced incidence of infection or sepsis, stroke, DVTs or venous thrombosis, emergency room admits, and ICU admits. So we want to make sure we're taking full advantage of our flu vaccinations, and children under 12 can get the flu vaccination. So it's super important for our little ones. I think, so there was a lot of back and forth about temperature screening and all this kind of stuff last year. And I think the look back on that is that it probably did help. It was a lot of work. I'm not completely sure of the benefit, but I'll tell you this, as an elimination strategy, as you're writing your programs, you need to do daily screening. Okay. So after you've asked everybody to get vaccinated or encouraged or educated or however your organization wants to approach vaccinations, daily screening is super important. Okay. I'm of a vintage where, you got up and you went to work and you toughed it out, and we can't do that anymore. Sick people are not welcome at work. And so however you achieve a daily screening, it's important. We've got to wake up every morning and say, do I feel well enough to go to work? Right? We can't have sick people at work anymore. I've got clients doing it with attestations. So there's just a sign at the door reminding everybody, look, if you don't feel well, you're not welcome. I've got folks doing it with an app on the phone. There's surveys that people have to fill out when they get to work, with a self-administered screening station. If they want to take their temperature, they can. All manner of ways of achieving a daily screen. Okay. But, and they're all, whatever works for your organization, you cannot give up daily screening. Okay. In some fashion. Remembering critically that the symptoms of Delta are different than the parent strain. Headache, sore throat, and runny nose for Delta are kind of things that, I've had a headache for 16 months, folks, right? So, and a sore throat, it's like, geez, do I have allergies or a runny nose? Like, we really mean you're not feeling well completely to, be cleared to come to work. Okay. So making sure that we're not passing over these symptoms versus, cough, fever, and, loss of taste and smell, which you just can't ignore. Okay. So just note that caveat there. Testing is still really important. A fair portion of the world has taken their eyes off of the role of testing. So as you're writing your programs, really think about where can testing fit in, whether you've got vaccines available or not, whether you're going to mandate or not. Testing the unvaccinated for sure, okay, is a strategy. It's not as good as a strategy as a vaccination for sure, but some type of routine testing for the unvaccinated absolutely makes sense, right? In the return to work plan, it's who's going to get tested, what type of testing. We've got way more tests available to us now than we did last year. A lot of rapid antigen tests are available now, a little less sensitive than our NATs, but the PCR testing, but it's right there. It's in the moment. And the way to combat loss of sensitivity with some of the antigen testing is to repeat it, right? Once per week, twice per week, right? Can you do it on site? Should you call in a third party, based on the location? Maybe you've got a remote workforce. And we've sort of develop plans for all those kinds of things. There are creative solutions to this, but please don't lose sight of testing wherever you can. Importantly, there are approved antigen and PCR at-home test kits, which we didn't have readily available last year. Where can that fit into folks traveling, coming back to an office? Those kinds of situations might make sense to do something like that. When you think about engineering controls, these are the unsung heroes that have gone in and looked at our ventilation system. These are our PEs and my CIHs that are spending a lot of time thinking about something that the employees you're responsible for are never going to see, right? And so, when we move out of that elimination bucket, we start thinking about our engineering controls and we're writing our plans. It's ventilation, 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 and making sure that you're aligning with ASHRAE in the States and REVA in Europe, and really trying as best as you can. I mean, there's some pretty lofty goals in those in the pandemic task force recommendations, but whatever you can do is going to help contribute to mitigating risk. And engineering controls, we also, always think about barriers. I've got a lot of clients that have plexiglass remorse, I can tell you that. As we're getting back to work and force, I think it's really important to have a look around about where the heck plexiglass went up last year, and does it still make sense? Okay. I had clients that put a plexiglass on a manufacturing line in between each person, including at the end of the line in front of the fire exit door, right? So that's crazy. So some crazy things have happened. So it's time to have a fresh look at where you've put barriers up. I want you to consider them very carefully. They may in fact hinder proper airflow. So we've done some CFD modeling and can see that, depending on where the diffusers and the returns are, plexiglass can create eddies around someone where they're not getting any fresh air, right? So aside from that, highly visible people that are seeing lots and folks all the way, they can be good reminders for everyone to stay back, right? Like, so the cashiers at the grocery store, or a receptionist, this kind of thing. So there may be a role for them for sure, but making sure that we're really thinking about them for large droplet control, and that we haven't overdone it on that. So I pulled up the ASHRAE guidelines. The REVA guidelines aren't that much different in Europe. It's getting people large quantities of fresh air filtered and turning it often. Okay, so that's really where we're at with this. Depending upon your building stock and the age, this MERV 13 filtration, like that may be crazy, right? But can you get a MERV 10, go up from your 8? Most older stock the fans can't handle this kind of pressure drop, but see what you can do, right? What quantities of fresh air can you bring in, right? You maybe can get from 15 to 20 to 30. I've got some clients who are running at 100% fresh air, and they're really lucky and they're spending a lot of money on that, right? Where can you go? This isn't an all or nothing, right? Like if you can't do anything, don't do nothing. Just see what you can do, right? I've got a lot of clients who have older historic buildings. They're just throwing up the windows, right? But aside from the ventilation, the filtration, really just making sure the system is working, right? And going and doing good audits. Are the filters that you've got, are they clearly inside the housings? Are the fresh air dampers working, right? I can't tell you how many times we've gone up to an air handling unit on a roof, and the dampers are rusted shut, right? So people aren't getting any fresh. The displays inside are looking great, right? But really making sure that you're doing good reviews of your ventilation system, and that you're communicating this out to your employees, right? Because this isn't anything that they see. And this is after vaccination, this is probably one of the largest things you can do to mitigate risk indoors, is thinking about their ventilation. So communicating with them about what you've done to look at their ventilation systems. When we think about administrative controls, things have come in and out of this bucket, probably more so than anything else. I will tell you, in the far right-hand corner on the bottom, Hand washing is the cornerstone of public health. Okay. So early on, we were scrubbing everything 10 times a day, introducing chemicals into spaces. We had a number of chemical response, right? People using concentrated chemicals because they were worried that it wasn't strong enough. And so we know now that the fomite route of transmission is not one of the largest routes of transmission. And a good thorough cleaning with disinfection, maybe more so when you know you've had a case, is sufficient. Okay. The way to break the fomite route of transmission is for people to wash their hands, right? Good, consistent hand washing protocols. Distancing, still important in areas where we don't have a lot of vaccination for sure. And masking is going to be real important. I've got a couple slides on masking. And then, I put meeting protocols there, but it's sort of all of the gathering protocols based on the rubric that you've got for vaccinations and ventilation and whether you can be inside or outside. So this administrative control section of your plans is really going to have to be super customized to your settings, and with a good section on good hand washing and good hand hygiene and hand sanitization. A lot of thought's going to need to go into this to sort of mitigate risk based on whatever rubric you've got. And then lastly, at the bottom of our triangle, at the end of our programming, we should be writing up what's going on with masks. Okay. And so, as I look back in the last 16 months, it's this mask thing is on and off and this kind and that kind. And what do we do? And, when, and masking has never been a bad idea. I don't think we had no flu season last year, right? So we know masks work for a number of different things for infectious disease. The motivation for everyone in the States anyway to remask was largely dependent upon the outbreak down in the Cape of Massachusetts. They had an outbreak in a community that was pretty much 75%, 3/4 vaccinated. But again, vaccine success story, right? So the morbidity mortality weekly report, the MMWR, reported on 469 cases we've known since then. We've got 965 cases, 75% were vaccinated, only 7 hospitalizations and no deaths, right? So this is vaccine success, but it did tell us that in a highly vaccinated community that Delta could still spread, all right? So there was mixed mask usage down the Cape. So this was one of the reasons that we had significant increases or significant push to remask. This is the data from Singapore that I was alluding to. You can see the red among the unvaccinated, the green among the vaccinated. These are viral particle loads, okay? We do now have that Netherlands data I was talking about saying, okay, even though the vaccinated and unvaccinated have same particle loads, not all of the particles in the vaccinated infected are infectious or viable, okay? There's some reduction, which is good, it's still measure, but it takes, you can see, it takes the immune system, a hot minute to get its boots on and get itself mobilized, okay? But you can see quick drops in the vaccinated folks' viral load, okay? So again, shorter duration, less symptomatic, but for those first few days, it is looking like they can transmit. So again, we got to get our masks back on. So masking absolutely remains a critical control regardless of vaccination status, okay? We know that outside is definitely a lower risk than inside. Doesn't mean that it's zero risk. So again, as you're pulling together your plans, I got a lot of clients that just moved everything outside, okay? But I've seen some outside locations that look pretty cozy, right? So some outside high density situations, tent walls are up, doesn't look exactly like outside, okay? So just be a little careful about your definition of outside when you're looking at things. I want to make sure everyone has seen this slide, okay? We had some recommendations for early masking early on. I don't need to explain to you EHS folks that respirators work because of the fabric they're made out of and the fit you can get to your face. So it's fabric and fit. So when we were looking in the far left at these surgical masks, which are the ideal material, right, for bacterial filtering efficiency, you had huge gaps on your cheeks. The secondary mask, a cotton mask over it, so two surgical masks isn't going to work. The objective is to get it to fit to your face. So the NIOSH, our National Institutes for Occupational Safety and Health, did a study. They were seeing super huge reductions in particle, about 95% reduction in particle penetrance. If you just simply did a knot in the ear loops very close to the fabric, and then tucked in the fabric and put it on. Okay, this is going to get it nice and tight to your face, and will help, again, protect both the wearer and those around them. So, everyone wants predictions. Everyone wants to know what's going to happen over the next few months in the winter. And I wish I had a crystal ball that was accurate. I think we need to get this off the dime from pandemic to endemic, and that's through vaccinations worldwide. Monitoring new variant emergence closely. We've got more genomic sequencing projects going on around the world, which should be hopefully early warning signs for all of us. Okay, so I'm glad to see that ramping up, and those are public-private partnerships with universities and government agencies, and so that's good. We need to spend more time and money monitoring those things in the way that we monitor the weather, right? And then the focus on vaccinations, really understanding durability and efficacy, getting them more widespread, just getting more shots in arms. Ventilation with a continued indoor quality focus, masking, and then testing wherever it makes sense. Okay, so with that, I will take some questions.
Thank you so much, Dr. Magari, for this fantastic presentation. And before we start the Q&A, I want to remind everyone about the evaluation survey we're asking you to complete. The survey will open in a different screen after this webinar. Your input is important because it'll help us improve our future webcast. Now let's get to some questions. The first one, do masks effectively filter out or prevent the spread of less than 5 micron particles, the smallest ones discussed earlier in this presentation?
They will. So the that surgical mask that I show you, it's that blue and white. It's or procedure mask. It's made of 3 layers of non-woven materials. So we know that non-woven materials have the best filtering efficiencies versus cotton, which is woven, which has larger particles, larger holes. The way to combat that is multiple layers of cotton. But for comfort, the 3-ply non-woven, they're usually melt blown or spun bound polypropylene polyethylene, is definitely going to get you that small particle filtration if you can get it tight to your face, right? So the trick is to make sure there isn't a pathway out the side of your cheek, right, for filtering. It's going to certainly help the forward path, but the tighter we can get those to your face, the better all particles are going to get filtered.
Our next question, will COVID-19 vaccines follow a similar path as flu vaccines? Every year a new vaccine comes out to cover new variants or new strains. So will an annual COVID vaccine be needed in the future, in your opinion, or based on facts as well?
Yeah, it's highly likely. I think, Ellen, we don't know. We know we need one sooner than later. There's a concept in immunology called original antigenic sin. Okay, and we're watching this very closely, or antigenic seniority. It's well documented with the flu boosters. Every year you get a flu booster. It's a little different, right? In the Northern Hemisphere, it's based on what's in the Southern Hemisphere. In the Southern Hemisphere, we try and guess. We guess every year. Every year it's a little different, right? But there's something about your immune system when you get that booster shot that says, oh, I know this. And it begins making antibodies to what you got boosted for. But primarily it makes antibodies to the very first flu strain you saw, whether it was by vaccination or natural infection. And we can see this in cohorts of 70 and 80-year-olds. We know what was circulating when they were, infants. And so we've got to be careful about boosting for SARS-CoV-2. And I think we're headed that way. With any luck, we can slow the transmission and slow the spread and the development of new variants through vaccination, like huge vaccination campaigns now over the next few months around the world. And that may limit the need for boosters to every other year, every third year, as we're doing surveillance and we're watching new agents emerge, watching trial participants and watching breakthrough infections in the vaccinated. That's what will determine ultimately the schedule. But right now, yeah, it's looking like we're headed towards something like that. With any luck, we've got combo shots, flu and SARS-CoV-2 being trialed, Novavax, for instance, a little bit more traditional vaccine platform with a purified protein. Maybe we can just give people them all at once. So we'll see. Time will tell.
So someone's asking, what evidence or scientific studies do we have regarding lasting immunity for those that are vaccinated?
So we've got quite a bit. You saw my vaccine efficacy slide. Those data are coming in weekly. There's cohorts being watched all over the world for sure for all the vaccine platforms that are out there. It's looking like, with the mRNA vaccinations, with Pfizer, Moderna, and some of the ABV vectors, the adenovirals, so like J&J and AstraZeneca, we're seeing pretty good protection through that's 8 to 9 months. So the trial participants from last summer around the world have been enrolled and followed for about a year now, and we're starting to see some breakthrough and some reduced efficacy. So I think right around that 1 year mark, which makes sense, we're going to need some kind of boost.
So our next question, we require a negative COVID-19 test for previously infected employees returning to work, and most hospitals and clinics provide documentation for this. How would this confirmation work with at-home test kits?
Yeah, so that's very interesting. So requiring a clearance test to come back to work. I've got some clients doing that. Got to be a little careful again, because those nucleic acid tests, like the PCR test, are so sensitive. People are testing positive long after they're infectious, long after they're harm to anyone. An antigen test for a clearance might be more appropriate. I've got some clients, so the at-home tests rely on the honor principle, right? So if you're doing an antigen test to clear people, those are rapid. Most all of them are rapid. You do it right there in front of you. So there are some companies that will mail folks a kit, and there'll be a telemed visit. So employees will have to log on, and a healthcare provider will watch them swab, so that eliminates a little bit of the honor principle. I've got some clients that are asking employees to take a picture of their, some of the antigen cards. There's like a 1 line or 2 lines, and you take a picture of it. Some of the clearance tests can be done like a PCR test. You can do a telemed visit to watch someone swab. They have to put it in the box and send it back to the lab. There's a couple of days delay, but that does eliminate the honor principle. So there's a couple of different ways that the folks have been doing it, but I actually don't have a ton of clients requiring a clearance test anymore. There's pros and cons to it for sure.
Our next question, is there a critical vaccination density needed to achieve a higher level of safety? How do employers best address vaccine refusal?
So that I think that person's asking me about herd immunity, and it's this concept that you have enough people vaccinated so that you're not you're breaking the chain of transmission, and you're not causing an outbreak in the unvaccinated. So for measles, for something that has an R naught of 18, something that's crazy infectious, you got to have like 95% of folks vaccinated before you can protect the 5% from being infected. For SARS-CoV-2, we don't know what the number is, but it's probably pretty high. So the Department of Homeland Security has documents out now that tell us that 1 to 3 virions of the Delta variant is contagious. So this thing is highly contagious. Okay. So it's, we were sort of, we epidemiologists are saying 70 to 90% of your population. I think it's probably closer to 80 or 90% or greater, depending on the variant circulating. but critically, I would say, not just looking overall at your organization what the vaccination rate is, but making sure by department for business continuity reasons, making sure that you understand who the unvaccinated are. So whether you do have a vaccine mandate or not, and we can do a whole webinar on that, making sure you understand where the unvaccinated people are, right? So for instance, you've got a control room, right, of critical business skill. If you've got 90% vaccination rates, but all the other 10% of the unvaccinated are in that control room or have a critical business skill, you still have a problem, right? So regardless of whether you mandate or not, I am encouraging people to ask, are you or aren't you? And that runs afoul of a whole bunch of privacy laws in around the globe. I get it. But as health and safety professionals, we have to anticipate, evaluate, recognize, and control. I can't do any of those things if I don't know where the unvaccinated people are, right? And so maddeningly turning our attention to protecting the unvaccinated from each other is what we've got to do. As far as the vaccine refusals go, it's tough. It's really tough, especially knowing that there's an abundance somewhere and some people are saying no thanks, and there's other people who are desperate to have them. Okay, so that's frustrating in and of itself as a public health worker. When I approach this situation, I've done a ton of vaccine education. It can't be a war or an argument. The objective can't be to win. Okay, these just have to be open-ended, as compassionate as possible, listening exercises. So you say, geez, tell me why you won't, or, what do you think? And then responding to clear up scientific, misconceptions, talk about safety, talk about efficacy. I talk with these folks about protecting their community and their loved ones. For sure, this is the most important thing we can do for our loved ones is to get vaccinated. Anyone that's got kiddos at home, there's kids under 12 can't get vaccinated. There's immunocompromised people. There's my elderly mother. We need to form a wall of vaccinated people around them. And so I usually try to bring those conversations around to protecting our loved ones. That's where I go with those.
So speaking of questions, what questions do you recommend asking on employee self-health screenings?
So making sure that you're clearing the list of symptoms. Do you have any of these list of symptoms? And the World Health Organization has a great list. The CDC has a good list. Making sure that you don't have close contacts so that are sick, that you haven't had a close contact that's sick, or living with a close contact. Those are sort of different scenarios, whether you go out to have dinner once with someone who turns up positive versus living with someone where you may have a continual exposure, are pretty much the high-hitting questions. Travel questions have come in and off depending on what's going on, around the globe and generally where people are traveling to and from. Most of the United States is considered an outbreak condition right now, so traveling from A to B doesn't matter too much. International travelers arriving back to the States, and I think most European countries need to have a negative test, and so you'd want to know about that on a questionnaire as well. So those types of things, and then a fever for sure. No one's welcome at work with a fever anymore for any reason.
So our next question, how long do unvaccinated people who test positive for COVID remain infectious with the Delta variant, and when can they safely return to work?
So it's about 10 days. So Delta is cooking up an infection and an infectious period quicker than it was for the alpha, beta, gamma. And after about 10 days, we know their infection has reduced such that the risk of post transmission or post isolation infection is very low. But the recommendation still in the States is for a full 14 days from the first day of symptoms that these folks should isolate. And that's the same for vaccinated too, Alan. It's not distinct. If you're positive, 10 to 14 days from your positive test or 10 to 14 days from symptoms. If you weren't symptomatic, 10 to 14 days from your positive test or 10 to 14 days from symptoms.
Our next question: what reassurances can you give people who have not been vaccinated to get vaccinated when it comes? What reassurance can you give to unvaccinated people about any long-term side effects?
So the long-term side effects of all vaccinations. So if you look at all vaccination history, all side effects have turned up within 3 months, and that's yellow fever, flu, the MMR, and the autism stuff. None of that has ever panned out scientifically. Okay, the health effects associated with any vaccinations tend to be very quick. They tend to be allergic reactions, and none of them have been documented after 3 months. Okay, so now we've got a year worth of trial data en masse. Our healthcare workers around the globe started getting vaccinated in December and January last year and this year. We have solid safety data. We have alerts for certain things. So we know that folks that are allergic to polyethylene glycol, some of the stabilizers and preservatives, polyethylene glycol or polysorbate 80 and the ABV vectors, that is absolutely a contraindication to taking the vaccinations. Thankfully, those allergies are very rare. We've seen some blood clotting issues. We know what to look for. We've seen some cardiomyopathy or pericarditis, excuse me. And we know what to look for. So the safety is super concerning, right? And that's why we're waiting to vaccinate kids. We need more trial data for sure for kids. They're not just little adults. They may need different doses even. For the safety data for adults, with the caveats that we've got, you can find them in the World Health Organization and the CDC websites. Their vaccines are very, very safe.
Our next question: can you get the flu shot and the COVID-19 booster shot at the same time?
You can. So early on, there were recommendations to just try and space things out. Folks were getting shingles vaccines and flu, and there were MMR boosters and whatnot. And there was some suggestion to space them out by a few weeks if you could. That recommendation has been removed, and you can co-administer now with anything, right? So, and I'm actively counseling clients, if you're going to do your annual flu vaccine, have some COVID vaccines available, whatever your third-party administrator is, ask them if they can do your COVID clinic as well. Maybe you'll catch some of the hesitant people for COVID that were kind of used to getting their flu vaccine every year. It's worth a shot to try and pick up a few more people that way too.
Our next question: regarding masking in the workplace, with the current variant, social distancing was often used in lieu of masking at many workplaces. With the Delta variant, is social distancing still a reasonable alternative in the workplace to masking?
I'm not comfortable with it. Right? As EHS professionals, we always want source control, right? So source control is the mask. And I do have some scenarios where when people are seated and they're distanced, clients are allowing them to take their masks off. But this is in a situation where we've got high vaccination rates, daily screening. Most of them are at 30 to 50% fresh air with 3 to 4 air changes. We have other controls in place. Again, we're looking for those layers. But where you can't assure those other things, it's best to ask people to put their masks back on.
We have time for one more question. What is your take on offering incentives to employees to get vaccinated? Also, once vaccinated and reaching quote unquote herd immunity at your company, what is your take on removing masks at that time?
Thanks, Alan. I'm going to answer the second question first, which is we still know there's a risk of transmission after vaccination. So I don't, even in a highly vaccinated community, I'm still recommending the mask usage. We wouldn't want to take anything home to our vulnerable folks. As far as incentivizing the shots, I absolutely think it's important to have both carrots and sticks. And maybe now we've hopefully educated and talked on the carrot side of things. And the smallest of thank yous has worked, right? So these should be small thank yous. I've had clients do all manner of creative things where they've asked and encouraged vaccinated people to sign one of the conference room walls, right? You get a pin. There's crazy social pressure to see a pin that says I'm vaccinated or I voted, right? So we've got a lot of psychosocial research on that. Having a manager 1 or 2 levels up from an employee call or email and say, hey, thank you for getting vaccinated. Really appreciate, you pitching in for the community. Okay. So the smallest of thank yous, cup of coffee, people getting vaccinated, getting a raffle ticket for something fun, once a month or whatever. On this, so trying as many carrots as possible. And a lot of that is education and talking and listening and very small thank yous. On the stick side of things, I've got clients that are saying, look, if you're not vaccinated, you've got to test once or twice a week. And by the way, you're going to either have to fully pay for it or there's a copay for it. Asking folks that are unvaccinated to pitch in more for their health insurance, right? They're certainly going to have a higher utilization. So balance of the carrots and the sticks, absent a mandate, really trying to balance them now.
Well, thank you, everyone. Unfortunately, we have run out of time. I'm sorry that we didn't get to everyone's questions, but unanswered questions will be forwarded to today's sponsor. Again, we also hope you take the time to share your feedback through our survey, and also just to let you know that this event has been recorded and a link will be available in a post-event email. This ends today's Safety and Health Magazine webcast. I'd like to thank Dr. Shannon Magari, our sponsor VETA, and of course, everyone who joined us today. Thank you and be safe.
Thanks.